Hello, everyone. Welcome back to another day of a review session for the NCLEX. And we welcome everyone who is already in the classroom. And for those new to the channel, we are also welcome to join with us today. And we are on day 66 out of the 90 days. We are offering the NCLEX course via www.stancoast-nclexcoaching.com, where we are offering our course for the entire 6 months. We have a wide range of topics that would be available through our on-demand videos, and also with the 20 hours of the animated video series as well, and where you can find the 3,000 NCLEX questions plus the 200 NGN test questions. So kindly check out the description box below and click into that link to know more about us. And please don't forget to like this video and also subscribe to this channel so that you can help out with those others that are also preparing for the NCLEX. Hello, everyone. Welcome to our session today. Now, we will be tackling on the different test questions, talking about fluids and electrolytes imbalances, and make sure that you are gonna, if you have some clarifications or any questions, you can post it in the comment section so you will be able to, we can follow up on those test questions as well if you need clarification. So kindly do that. All right, guys, let's start with our test question today. We have our test number 1. A patient recovering from a car accident is receiving treatment for shock, and the healthcare provider prescribes 6% dextran 75 intravenously. Which result should the nurse anticipate from this infusion? Is it A, reduced urine output, B, enhanced blood oxygen levels, C, increase fluid in the tissues, D, heart rate and blood pressure stabilization? So we are being asked here about a case of a patient that had a car accident and now is getting a treatment for the shock. And you are given here a scenario wherein he is about to receive 6% dextran 75 IV. So as the nurse in this situation, what you should anticipate after the infusion? Will that be letter A, B, C, or D? While you are selecting that answer, let me have the rationale for letter A. If you answered letter A this time, reduced urine output, that is incorrect. This is not the desired outcome of this infusion, as we know that the dextran 6% is a colloidal solution. It is going to expand the plasma volume. Dextran is what we call as a plasma expander. And take note, in our scenario, the patient has shock. We really don't want to worsen, right? We need to treat this patient with the use of a plasma expander. What it does is actually, it can increase the blood volume. It will improve the circulation. It can also increase the urine output, as the kidneys will be receiving more blood and it will be able to filter more efficiently. So reduction of the urine output is wrong. The expected outcome for this patient is an increase in urine output. Although this is not really the main therapeutic response to the medication, it can help in perfusing. It can increase the blood supply into the kidneys. So the expected result here is urine output that is increased. Again, this is not the primary effect of the dextran. It will allow an increase in the volume, circulating volume in the blood vessels. If you had answered letter B, enhanced blood oxygen levels, is that the correct answer? The goal of the therapy is not to increase the oxygen levels, right? There is going to be an increase in the plasma volume instead. It will stabilize the circulating fluid volume. We know that the oxygenation is directly influenced by other interventions, maybe application or administration of O2, inhalation, but it's not going to be increased, where the oxygen levels will not be enhanced by the administration of the dextrin. So we are not going to select this option. If you had answered letter C, increase fluid in the tissues, will this be the correct answer this time? Of course not. If we are talking about increasing fluid in the tissues, this is pertaining to the interstitial fluid. So this is not the correct option. This pertains to interstitial compartment. Guys, if we are talking about the plasma expander right here, which is the dextrin, the cells right here surrounding tissues, and we have the interstitial spaces right here, interstitial compartment. What actually happens is that the dextrin will draw fluid from the medication. The dextrin will actually draw fluid from the interstitial compartment back into the bloodstream. And that is why there will be restoration of the patient's circulating fluid volume because of that effect. It can draw fluid from the interstitial compartment back into the intravascular spaces. So the patient's blood pressure here will be higher at this point, as we are talking about a patient that is in shock. All right, so letter C is incorrect. Now, if you had answered letter D, heart rate and blood pressure stabilization, of course, that is the goal of our therapy here. We are talking about a case of shock. So here are your clues: blood pressure stabilization and also heart rate stabilization. Remember about the effect of the dextrin? It will pull fluid from the interstitial compartment into the vascular compartment. This is why it is called plasma expander. All right, guys, let's move forward to our next question. Again, our answer here is letter D. Let me just mark it as letter D. Moving forward to number 2. A patient with severe gastroenteritis is admitted and their electrolyte panel shows a serum sodium level of 140 milliequivalents per liter and a serum potassium level of 3.5. The doctor prescribes an IV solution of 5% dextrose with normal saline and 20 milliequivalents per liter of potassium chloride at 125 mL per hour. What should the nurse do before starting the infusion? Is it A, assess the patient's urine output? B, ask the doctor for arterial blood gases? C, suggest starting with a potassium bolus? And letter D, recommend a low sodium and low potassium diet. So your patient here has a case of severe gastroenteritis. You will expect that this patient will be losing a lot of fluids, losing a lot of electrolytes. And now that you had checked their electrolyte levels, it shows that their sodium level currently is at 140, serum potassium level of 3.5. But here in this scenario, you are about to administer an IV fluid of D5. So that is dextrose. D5 with normal saline, 0.09% NaCl, plus it has 20 milliequivalents of potassium in it. Take note, guys, your patient's potassium level is 3.5, and you're actually replenishing the patient's, about to replenish the patient's fluids with a potassium 20 milliequivalents at 125 mL per hour. So what would be the safest answer this time? If you answered letter D, recommend a low sodium and low potassium diet, would that help this patient that has a borderline potassium level? So you are selecting low sodium, low potassium diet. If that's the case, could that help the patient? Well, if you're going to suggest a low sodium and low potassium diet, it is not appropriate this time, given that the current potassium level is actually in the normal range. There's nothing worrisome about the 3.5. And as we know that the dietary interventions are not immediate actions before an intravenous therapy, not immediate action. So what should be your focus this time is to actually monitor this patient for a potential hypokalemia. So we are marking letter D as a wrong option. It is not an immediate action. Of course, it is not going to deal with this patient that is about to take this IV fluid. If you had selected letter C, suggest starting with a potassium bolus, yeah, this could instantaneously cause cardiac dysrhythmias into your patient if you're going to administer potassium bolus. Never administer potassium in a bolus, because if you're going to do that, it can lead to cardiac arrest. Never do that. So you are eliminating letter C as well. If you are picking letter B, ask the doctor for arterial blood gases. Is there such a need for ABGs this time? There isn't, okay? This is only ordered if there is possibly signs and manifestations of the metabolic acidosis, alkalosis, respiratory acidosis, respiratory alkalosis, and we don't have that information about those imbalances, right? We don't have that in the scenario. So we don't have any other option but to assess the patient's urinary output. Guys, whenever you're going to deal a patient with hypokalemia, and if you have an order to replace their potassium, make sure that you are addressing first their hydration. Make sure that they have enough urinary output, because if you're not going to address that first, it can cause the potassium to accumulate in their bloodstream. Take note about that. Always check the urinary function. Always assess the urinary output before administering the potassium, okay? Because if they have adequate urinary output, this simply means that their kidneys can excrete potassium and it will prevent the hyperkalemia. So our correct answer here is letter A. Always assess the urinary output. If they don't have that adequate urinary output, address the patient's hydration first thing, okay? Do not proceed with administering the potassium for this patient, all right? Let's have a number 3. A patient is being treated for dehydration with an IV infusion of 5% dextrose and half normal saline plus 20 milliequivalents per liter potassium chloride at 125 mL an hour. Upon review of the latest lab results, the nurse notes a serum sodium level of 140 milliequivalents per liter and a serum potassium level of 3.6 milliequivalents per liter, with a urine output at 250 mL over the last 12-hour shift. What should the nurse do? Is it A, discuss increasing the potassium chloride to 40 milliequivalents per liter with a provider? B, continue the current IV fluids and monitor the patient closely? C, consult with a medical provider about raising the fluid rate to 200 mL per hour? And letter D, stop the IV fluids and inform the provider of the assessment findings. Your answer, please. So your patient now is being treated for their dehydration, and they are receiving IV fluid D5, half normal saline with 20 milliequivalents of potassium at 125 mLs an hour. Now your patient's lab results showing 140 of sodium, whereas their potassium level is 3.6. However, your patient's urinary output is only 250 mLs over the last 12 hours. All right. Your patient's urinary output is only 250 mLs in 12 hours. So what is the hourly urine in this patient? Okay. If you had answered letter A, discuss increasing the potassium chloride to 40 milliequivalents per liter with the provider. You are going to increase, you are suggesting that you are supposed to, increase the concentration. This is incorrect. The patient's potassium level is at 3.6. Is there a need to increase the concentration? No. Your patient's potassium level is already 3.6, which is within the normal range. You're eliminating letter A this time. If you're going to increase the concentration to 40 milliequivalents, this could lead to hyperkalemia, especially that the patient has low urine output. There is oliguria. Your patient is only urinating about 20 mLs per hour. Is that correct? Is it 20 mLs per hour? Yes, or 21 mLs per hour. That's 20.8 mLs per hour. So there's no need for us to increase the potassium content in our IV fluid. What about letter B? Continue the current IV fluids and monitor the patient closely. Guys, your patient has been oliguric for 12 hours. Do you still need more 12 hours to keep monitoring the oliguria? No. You're actually compromising the patient's urinary function. The kidney function here is probably deteriorating. So, if you are just going to continue observing the patient closely, you're actually harming the patient. There's already 12 hours that had passed. That is enough to cause renal failure in your patient. So, if you again selected letter B, remember that with oliguria, it can lead to more accumulation of potassium in the bloodstream. We are eliminating letter B. If you had answered letter C, consult with a provider about raising the fluid rate to 200 mLs per hour, all the more that you are actually increasing the intake of the potassium, which is unsafe in this manner because your patient's urinary output is still in the low side, oliguric still. So the correct answer this time is to select letter D, stop the IV fluids, and inform the provider of the assessment findings. This is the safest nursing intervention this time. Given that they have oliguria, and of course, with that potassium that they are getting, they already are normal, right? 3.6. So our next step here is to make sure we discontinue this IV fluid, and you inform the medical provider right away that their urine output has been really low for the 12 hours. And once they are informed about that, they probably would give you some more additional orders. That would be the initial step. You gotta discontinue the IV fluids, give them a call right away, and hopefully they're going to give you some more orders to continue hydration. All right. So the correct answer here, it is letter D. Let's move forward to item number 4. A patient has a serum potassium level of 2.7 milliequivalents per liter, and the provider has decided that 200 milliequivalents of potassium is needed to correct this deficiency. Decided that 200 milliequivalents of potassium is needed to correct this deficiency. It is not yet an established order. Decided for this patient that has a potassium level of 2.7. How should the nurse plan to administer this potassium replacement as part of the care plan? Will that be letter A, as a single dose, 200 milliequivalents oral tablet? B, as an IV bolus over 15 to 20 minutes? Or is it C, in an IV solution at a rate of 10 milliequivalents per hour? Or letter D, in an IV solution at a rate of 45 milliequivalents per hour? What is your answer this time? Your patient has a potassium level of 2.7. How are you going? What is your plan here as a nurse taking care of this patient? Okay, I'm seeing answers. C's this time. What about letter A? As a single dose of 200 milliequivalents oral. When you are going to give this full dose of 200 milliequivalents, this is unsafe because this can lead to gastric irritation and also ulceration. And another thing is that this patient that will be getting 200 milliequivalents can develop into cardiac dysrhythmias as well. Aside from the ulceration and irritation, they're gonna develop the cardiac dysrhythmias, GI irritation. Never give a single dose of potassium, even orally. What about letter B? As an IV bolus over 15 to 20 minutes, like I said earlier, you're never going to give IV potassium bolus because this can lead to the cardiac arrest. It has to be regulated. It has to be given slowly in a diluted solution to prevent life-threatening dysrhythmias. If you had answered letter D, in an IV solution at a rate of 45 milliequivalents per hour, no. This is an action that is too rapid, okay? Too rapid administration. This can also lead to cardiac arrest. And if you are the nurse, especially in the med-surg setting, if you have an order to give potassium IV, the recommendation to administer the potassium, for example, for the first dose, maybe potassium chloride, let's assume the first order is 40 milliequivalents. And in most cases, this is going to be diluted, right? It can vary from one hospital to the next. Some hospitals would carry the 40, or let's say the 40 milliequivalents in about 125 ml solution, sodium chloride. Or maybe they will give you a preparation that is 10 milliequivalents in 50 mLs. But if you're going to be asked about the recommended hourly rate of the potassium, mostly it is going to be only 10 milliequivalents per hour. That is the hourly infusion. I'm sorry, that's not per liter, but per hour rather. Let me change that to per hour. This is the hourly infusion rate. The medication should be run in an IV pump, and your patient around this time that is hypokalemic, they should be having that cardiac monitoring. All right? I should say continuous cardiac monitoring when they are receiving the potassium infusion, plus that they are hypokalemic already. This is the safe practice. In the critical setting, this is going to be a little bit different, okay? In the med-surg setting, you're going to administer that 10 milliequivalents per hour via a peripheral IV access, all right? In the telemetry or in the ICU setting, they will do it differently. They're going to administer probably the medication to 20 milliequivalents per hour. with cardiac monitoring continuously, and plus it is administered via a central line. Okay, that is the caveat here, especially in the ICU or the progressive care unit. They should be administering that. It could be 10 to 20 milliequivalents per hour, provided that they are administering it via the central line, of course, with the continuous cardiac monitoring. That's the difference there in med-surg and progressive care unit and also ICU. Let's have number 5. A patient's lab result indicates serum sodium level of 140 milliequivalents and per liter and a serum potassium level of 5.4. Which intervention should the nurse anticipate the healthcare provider will order? Is it A, low potassium diet? Is it B, intravenous sodium bicarbonate? C, kyaxylate and sorbitol? D, use of salt substitutes. Your patient's serum sodium level is 140 milliequivalents per liter and potassium of 5.4 milliequivalents per liter. So, which intervention should you anticipate the doctor will be ordering? While waiting for your answer this time, let me start with letter D, use of salt substitute. If the medical provider, if you're anticipating that the medical provider will order the salt substitute, remember that they are actually high in potassium, right? And your patient already has hyperkalemia. You don't really want to add more potassium in their bodies, right? Because salt substitutes are rich in potassium. This could exacerbate the hyperkalemia, and this should be avoided at all costs. We are eliminating letter D. Now, take a look about a 5.4. Does this really necessitate letter C, kyaxylate and sorbitol? Do you think that this is really the treatment of choice this time? 5.4 is considered as mild hyperkalemia. Take note, guys. 5.4 is mild hyperkalemia. We are only going to expect the prescription of kyaxylate and also the sorbitol if there is severe case of hyperkalemia. Let's say greater than 6, all right, or greater than 5.5. This is the time when we are going to expect the administration of kyaxylate and sorbitol only for severe cases, could be moderate to severe in such cases, right? Moderate to severe hyperkalemia. Our patient's potassium level is not that high. It is a mild form of hyperkalemia. And so the letter A will be the best choice this time. Low potassium diet is the correct answer. This is appropriate for this patient. This low potassium diet can manage the mild hyperkalemia. We are going to restrict their intake of high potassium containing food items. All right. So if you had answered letter B, sodium bicarbonate, why would you give a patient with a sodium bicarbonate in this patient? Is there a indication that they are in a metabolic acidosis? No. No manifestation of metabolic acidosis. And the use of the sodium bicarbonate is not warranted this time. Not indicated. You're only going to expect administering the sodium bicarbonate if there is metabolic acidosis. Okay? And remember, guys, that when you have a patient that has severe metabolic acid, or a case of metabolic acidosis, rather, there is also a high level of potassium, severe levels of potassium. And so this is not indicated in this scenario. Same thing with letter C and letter D. Guys, Our correct answer for this test question is letter A. This is manageable by restricting potassium intake. Let's have number 6. A newly admitted patient with cardiac dysrhythmia is scheduled to receive digoxin. The patient is also taking hydrochlorothiazide and uses over-the-counter laxatives regularly. Before administering digoxin, which electrolytes should the nurse check most carefully? Is it A, calcium and magnesium, B, sodium and calcium, C, potassium and chloride, D, potassium and magnesium? Patient is admitted with cardiac dysrhythmia and now is scheduled to receive digoxin. However, they're also taking HCTZ, which is a diuretic. And also, they're using over-the-counter laxatives regularly. So before you administer the digoxin, which electrolytes you should pay attention in checking? Would that be A? Would that be D? Would that be C or B? All right, very good. I'm seeing letter D's this time. If you had answered letter A, calcium and magnesium, this is incorrect. We know that the calcium is also important in the cardiac function, but it is not directly related to digoxin toxicity, okay? Even though it can affect, all right? It is not really the main electrolyte that you should be paying attention. There's more than this too. What about sodium and calcium? We know that it is also important to check the sodium levels, but it does not significantly influence the effects of the digoxin as well. Even though that the calcium has a role in the conduction, but it is not really the immediate concern about digitalis toxicity. There's more than these two. What about letter C, potassium and chloride? Yeah, correct for the potassium. However, for the chloride, no. There is no close relationship between chloride and potassium. We are only going to worry about the chloride if there is going to be acid-base imbalance, not about digoxin toxicity. Again, guys, the potassium in option C is okay. Yes, we need to monitor potassium, but chloride, no. This is much more associated with acid-base imbalances. If you had answered letter D, that is the correct answer, because we know that with the potassium, both the hypokalemia and also hypomagnesemia, these can cause the digoxin's effects. It will place the patient at risk for digitalis toxicity. Okay, so these are the two most important electrolytes that you should pay attention to, because if they are both low in their ranges, this can lead to digitalis toxicity. And remember all those manifestations, the early and the late manifestations. And also, if there is dig toxicity, remember about that medication, the Digibind. Remember that? Yes. Again, guys, these are the primary electrolytes that you should pay attention. That would be letter D. Especially that they are using the hydrochlorothiazide. What does that lead to? Remember that it can cause hypokalemia and also hypomagnesemia. It can lead to that low electrolyte count. And plus the laxatives regularly. This patient will be losing lots of potassium as well through the GI tract because of the laxative effect. It is going to cause hypokalemia in this patient. Plus the digoxin. This will exacerbate it. It can lead to dig toxicity. Now, guys, let's talk about the effect of the digoxin, especially if there is if there is electrolyte imbalances. So take note about those imbalances that I have discussed way back in our cardiology concepts. Primarily, if there is hypokalemia, there is a higher risk to developing Digtox. Another is hypomagnesemia. And then we also have the hypercalcemia. All right. So what is really the action of the digoxin here towards the cardiac cell? So we are talking about the myocyte this time, the cardiac cell. But before we're gonna go to that level, we need to understand first that the heart cell is basically gonna have that sodium potassium adenosine triphosphatase pump. This is the channel that is supposed to allow exchanges of the sodium ions. So, sodium ions, like 3 of them. The action of the sodium potassium ATPase pump is basically to allow exchanges of 3 of the sodium ions to be what? Expelled into the extracellular compartment, while it will allow the entry of potassium ions, 2 potassium ions, to get into the myocyte. All right, so take note of that. This is the role of the sodium potassium ATPase pump. Again, it will allow the exchange of the sodium 3 ions, and it will be expelled from the myocyte into the outer section or the extracellular compartment. However, it will allow the entry of 2 ions of potassium from the extracellular compartment into the heart cell. So what's the reason about these exchanges? This is to help maintain the cardiac activity, because if there is no proper maintenance about the gradient, this can cause cardiac dysrhythmias. This is the normal mechanism. This is what is supposed to happen in the normal condition. However, if the patient will be taking the digoxin, if they're going to be taking digoxin because they probably had heart failure, this digoxin will block the sodium potassium ATPase pump. This is already blocked by the digoxin. So what's going to happen if there is a blockage of the sodium potassium adenosine triphosphatase pump? This will now increase the entry of the sodium ions into the cell. All right. Again, there will be increased sodium concentration inside the cell. And because of that increase in the sodium in the myocytes, this will also impair the sodium calcium exchanger, or known as the NCX. This is what we call as the sodium calcium exchanger. So this is another important channel that should allow the exchange between the 2 electrolytes, sodium and calcium. Sodium calcium exchanger. Since there's already an elevation of the calcium, or the potassium rather, in the heart cell, this will impede the activity of the NCX pump. So what's going to happen? Instead that this NCX is supposed to function in normally forcing out the calcium ions from the cardiac cells into the extracellular compartment, well, this is already impaired, right? So what's going to happen is that there is also an increase in the concentration of the calcium ions in the myocytes, plus a concentration of sodium in the myocytes as well. So this will now increase the cardiac contractility. The heart cells will be more excitable this time. Increased contractility and more excited. Now, when this happens, especially when the patient is taking that digoxin, there's blockade of that sodium potassium ATPase pump, and this can also enhance the increase of the calcium ions inside the cell, plus the sodium. Now, the patient here will develop the cardiac dysrhythmia, especially if your patient has hypokalemia, because as we know that the ATPase pump is supposed to allow the exchange of the sodium ions to be expelled, right? It's supposed to allow the exit of the sodium ions out of the cell, while it will allow the entry of the potassium ions into the cell. But this is already blocked by the digoxin. So what's going to happen instead here is that there is now hypercalcemia. I mean, it's not hypercalcemia, but an increase in the calcium level inside the cell. Not hypercalcemia, but increasing calcium in the cell. So what's going to happen here? The patient will have that increased contractility, excitability. This is what's going to cause that digoxin toxicity. And the same thing with the hypomagnesemia, because the hypomagnesemia can also contribute to the low potassium level. It can worsen the low potassium. So this is another contributory factor. And of course, if there is excess calcium level in the bloodstream, and since there is already blockade of that pump, it will allow more entry of the calcium ions into the heart cells, causing more increased contractility, increasing excitability. So this will lead to that condition called dig toxicity. Okay, so that's enough for the dig tox. Let's talk about number 7 this time. A patient in the ICU is scheduled to receive digoxin. Their latest lab results show a serum potassium level of 2.9. What is the nurse appropriate response? Is it A, give the digoxin and closely monitor the ECG, or B, withhold the digoxin and inform the provider about the lab results, or is it C, request an IV bolus of potassium, or is it D, ask for an order for oral potassium supplements? So take note, guys, your patient has hypokalemia 2.9. and they're supposed to receive digoxin. So what would be the safe step here? Is that to give digoxin and closely monitor the ECG? Or are you going to withhold the digoxin and inform the medical provider about the lab results? Or are you going to request IV bolus of potassium? Or will you ask for an order for oral potassium supplements? If you had answered letter A, give this digoxin and closely monitor the ECG, that is already incorrect, right? Whenever there is hypokalemia, do not give digoxin. That's the rule. Because when that happens, it can lead to dig toxicity. Causes digoxin toxicity. If you had answered letter D, ask for an order for oral potassium supplements. Would that be the priority this time? Especially that your potassium, the patient's potassium is 2.9. Well, we know that oral potassiums may be useful, right? But this is not appropriate, especially if we are going to correct a severe hypokalemia. This is already quite low. 2.9 is already considered a severe hypokalemia. Especially in the critical care setting, we need to correct the potassium that is low. Oral potassium is not going to be appropriate in this severe hypokalemia. Oral potassium is indicated for mild hypokalemia. Maybe 3.4, 3.3, 3.2, anything below 3. Oral potassiums oral potassium chloride will not be appropriate to get that restoration or to establish or to re-establish the normal potassium. It won't be able to restore in that specific time frame. What about letter C? Request an IV bolus of potassium. This is incorrect. Never administer IV bolus. What you should do instead is to hold or withhold the digoxin dose, and you're going to notify the medical provider about the hypokalemia. This is the safest nursing action. As we know that the dig can lead to dig toxicity if there is hypokalemia. So make sure that they are aware about that. And hopefully the medical provider, once they are informed, they are going to order IV potassium chloride replacement first before you're going to give the digoxin. Okay? So in this case of severe hypokalemia, of course, they have an order for digoxin. So again, contact the medical provider, inform about the severe hypokalemia, and possibly get an order for IV potassium replacement. We can increase their potassium safely by administering the IV potassium. That potassium at a rate of 10 milliequivalents per hour. And it could vary. In some hospital settings, in one episode, what they would want usually would be 40 milliequivalents in an IV bag. And then you are going to administer that IV bag for at least, the rate of correction here will be 10 milliequivalents per liter. So for example, if that 40 milliequivalents of potassium, okay, 40 potassium, KCl, again, it can vary from one hospital to the next. Most often, if they are going to order 40 milliequivalents per liter, 40 milliequivalents of potassium, this is usually diluted in normal saline at 100 mLs of normal saline. And so when you are going to administer this according to the recommended 10 milliequivalents per hour, so how are you going to administer this one? In order for you to safely give this drug, how are you going to administer this? What would be the hourly rate per ml? So what you're going to do here is what? 100 mLs. Since we are 40 mLs in 40 milliequivalents per 100, 40 milliequivalents per 100 ml of saline. So you're going to have to calculate that. What would that be? You're going to have to divide the 100 by 4, right? So let's take a look at that one. So that would be 25 mLs per hour. If we are going to administer that in an hourly rate, 25 mLs per hour. So this is pretty much like 10 milliequivalents per hour, right? 10 milliequivalents per hour, which is equivalent to 25 mLs per hour. So that should be the recommendation that you should follow, especially if you are going to administer in a peripheral IV access, and provided that your patient is monitored in a continuous cardiac monitoring device, always when you are replacing. Okay, now let's proceed with number 8 this time. Back to number 8. A patient is prescribed 10% calcium gluconate to treat serum potassium level of 5.9 milliequivalents per liter. During the medication history review, which of the following medications would raise concern? Is it A, digitalis? Is it B, hydrochlorothiazide? C, hydrocortisone? D, vitamin D? Again, your patient is prescribed 10% calcium gluconate to treat a serum potassium level of 5.9 milliequivalents per liter. During the medication history review, which of the following medications would raise concern? Is it A, digitalis? B, hydrochlorothiazide? C, hydrocortisone? D, vitamin D? your answer. If you had answered letter D this time, vitamin D, this is incorrect. There is no relationship between vitamin D and the digitalis. No relationship at all. We know that the vitamin D is going to increase the absorption of the calcium in the GI tract, right? It does not have an interaction. They don't have any relationship at all. So if you had answered letter C, hydrocortisone, what do you think is in letter C? We know that hydrocortisone, it is a steroid, right? It can influence the electrolyte balance. It can promote sodium retention. Promote sodium retention. And it can also cause potassium loss via the kidneys. But it doesn't really interact with the calcium gluconate. So it doesn't really pose an immediate concern, right? If you had answered letter B, hydrochlorothiazide, which is a thiazide diuretic, what do you think about that? Hydrochlorothiazide. The hydrochlorothiazide can affect the potassium level by causing its excretion via the kidneys, but it doesn't really cause an immediate interaction with the calcium gluconate, right? It doesn't. However, if your patient is taking digitalis, and if they are taking calcium gluconate, if there is a possible administration of calcium gluconate because they're having a hyperkalemia, then this can lead to dig toxicity. Digitalis toxicity. Guys, what is the role of the calcium gluconate here? The calcium gluconate is ordered for this patient because of the hyperkalemia. Gluconate. This is prescribed to treat the hyperkalemia, which is going to cause cardiac excitability, intended for that cardiac excitability. Remember that when the patient has when the patient is going to take the if the patient has hyperkalemia, the heart cells are becoming more excited this time. They are so responsive to any kind of stimuli, right? And this is the reason why the calcium gluconate is ordered. This is to stabilize the heart cells. That is the primary reason why the calcium gluconate is ordered, to stabilize the cardiac cells because of the excitability, because of the hyperkalemia. Now, since we are going to administer calcium gluconate, you got to be careful here, because when you are just administering, this is enough to cause that cardiac, or this is going to cause the digitalis toxicity. Remember, the hyperkalemia, which is going to be represented by the injection of the calcium gluconate. This is enough to cause more excitability of the heart cells. So you got to be careful when you are administering this medication. Okay? So what would be the appropriate action for you as the nurse taking care of this patient? You should carefully administer this medication, the calcium gluconate, first, and make sure that you're informing the medical provider, hey, our patient is taking digoxin, or yes, they are taking digoxin. What do you want me to do at this point, since there's a need for us to administer the calcium gluconate? So it's either that you're going to ask for an order to hold the digoxin at this instant in order to prevent the digitalis toxicity complication. Okay, so that would be our next step. Let's have number 9. A nurse is preparing to administer IV calcium gluconate to a patient. Which of the actions are appropriate? Is it A, administer via a central line? Or is it B, check for signs of trousseaux and also Chvostek's? Or letter C, administer rapidly as a bolus? Yes, Roxanne, that is correct. We need to have continuous cardiac monitoring when we are administering the calcium gluconate as well, especially that they have the electrolyte imbalances going on. Is it C, administer rapidly as a bolus, or is it D, combine with sodium bicarbonate in the same infusion, or E, monitor the patient's ECG, or F, report a serum calcium above 2.5 milliequivalents per liter? So you're preparing to give the patient IV calcium gluconate. So which of these actions are appropriate? Will you require, will you need to administer that via a central venous catheter? Or are you going to check for signs of trousseaux and Chvostek sign? Or are you going to administer that as a bolus? Or will you combine it with sodium bicarb in the same infusion? Or will you monitor the patient's EKG? Or are you going to report a serum calcium level above 2.5 milliequivalents per liter? Hang on a second, guys. Let me correct this option number 5 or letter F. Hang on a second. We are on, this is supposedly 12.5 milligrams per deciliter. Hang on a second. Let me correct that. That is an error. Number 9, we are on page 1402. So hang tight. This is error. That is 12.5 milligrams per deciliter. Okay. Please take note. This is already corrected. Question number 9 is corrected. So you are supposed to administer calcium gluconate. But which of the following actions are appropriate this time? Will you do A, B, C, D, or F? If you answered letter A this time, letter A, administer via a central line. This is not required when you are administering calcium gluconate. Never. It is not a requirement. You can administer the calcium gluconate through a peripheral IV access. Okay? Peripheral IV access. This is not required. Okay. So we are eliminating letter A. What about letter B? Check for signs of trousseaux and Chvostek signs. Remember, when you have a patient that has a hypocalcemia, whenever they are going to have a drop, hypocalcemia, which is less than 8.6 milligrams per DL. Take note about the hypocalcemia. Whenever they are hypocalcemic, this patient will be prone to developing these manifestations. When you're going to tap their cheek, they will have the twitches. We call that Chvostek sign. Or if you're going to measure their blood pressure, this can cause the spasm, the trousseau sign into their arm. So when the blood pressure cuff is squeezing their arm, it kind of like, it will move, it will cause their arm to move inwards. There is that, what we call a trousseau sign. And then with the tapping of the cheek, it can lead to that Chvostek sign. So these are signs of tetany, actually. Increased irritability of the muscles because of the lack of calcium. So B is one of those actions that you should be doing. What about letter C? Administer rapidly as a bolus. Never administer this medication as a bolus. It should not be given as a rapid bolus due to the risk of severe complications. It can lead to cardiac dysrhythmias. Never give that as a direct rapid injection. So we are going to eliminate letter C. What about letter D? Combine with a sodium bicarbonate in the same infusion. Will that be safe? No. Should not be mixed with sodium bicarbonate because it can lead to precipitation. That is the result of mixing the sodium bicarbonate with a calcium gluconate. Never do that. It will render the infusion, or it will render the medication ineffective, and it's going to be harmful to the patient as well. What about letter E? Monitor the patient's ECG. Of course, if you're going to administer calcium gluconate for a patient that has a hypocalcemia, you got to make sure that you are continuously monitoring their heart activity with the use of that continuous cardiac monitoring device in order to capture those arrhythmias. So letter E is one of those correct answers. If you had answered letter F, report a serum calcium level above 12.5. We know that 12.5 is already elevated, right? This is already a hypercalcemic level. So again, that is another nursing action that you should be doing. Guys, please take note. I'm using the Lippincott range of the calcium level. Normally, the calcium should be in this range, 8.6 to about 10.5 milligrams per DL. So that should be the safe range. I don't know about Saunders, but I've seen it before that their range is about 9.2 or something to about 11. Yeah, they have a weird range, so I'm not even touching that. I always refer to the Lippincott, especially for the lab results, which is more consistent with the general medicine literature. So I'll stick to the Lippincott range of electrolyte values. Okay, so our correct answer here is again letters B. Very good. Thank you, Gul. So our correct answers here are letters B, letter E, and letter F. We know that letter F is already high, but reporting it would be also beneficial. Let's have number 10. A patient with suspected severe hypocalcemia is awaiting serum electrolyte results. Suspected severe hypocalcemia. You are still waiting for the lab results. What symptoms should the nurse look for? Select all that apply. Is it spasms of the larynx? Or is it B, tiredness? C, muscle weakness? D, gastrointestinal upset? E, tingling in the fingers? And letter F, mouth twitching. You're looking for the manifestations of hypocalcemia. What would be those signs of hypocalcemia? You're suspecting that they have hypocalcemia. However, you don't have the lab results yet. But what are those symptoms that you should look for in this case? Will that be A, B, C, D, E, F? If you answered letter A, spasms of the larynx. Yeah. This is one of the correct answers. As we know, in a case of hypocalcemia, this is actually this is one of the symptoms, guys. They will have that increasing spasms of that airway. This can lead to the laryngeal spasm. So this is a priority. Airway compromise. Okay. So if you are going to hear them with a stridor, that very noisy passing of the air in that narrowed airway, yeah, this is a sign that your patient has hypocalcemia, especially if they had thyroid thyroidectomy, wherein there is inadvertent removal of the parathyroid gland. Yes, this is one of those. What about letter B, tiredness? Is this a specific manifestation of hypocalcemia? Or will this call for a immediate, is this an immediate symptom of hypocalcemia? Again, tiredness is not really specific to hypocalcemia, so we are going to eliminate that one. Not specific. Although it can cause, but it's not specific to hypocalcemia. What about letter C? Muscle weakness. Will that cause muscle weakness? Again, this is a non-specific manifestation. The patient is much more linked towards muscle tetany. So we are also going to eliminate that one. Again, non-specific to hypocalcemia. There are so many other conditions that can cause muscle weakness, like hypokalemia, right? Or hyponatremia. What about letter D? Gastrointestinal upset. Will this be one of those? No. The patient that has the gastrointestinal upset, let's say vomiting or nausea, they are not typically indicators for the low calcium level. These are more typical manifestations of neurological symptoms. So we are also getting rid of the letter D. What about letter E? Tingling in the fingers. Yes. The numbness or tingling in the fingers or extremities, the toes, this is going to signify that there is hypocalcemia. Tingling in the fingers or around the mouth. That's another sign of hypocalcemia. Or it could be tingling in the toes. That's another manifestation. And then we also have the mouth twitching. There's also tetany. Oops, sorry. Let me get rid of this. Tetany. Those Schwarzkopf's and Trousseau signs. And Trousseau signs. These are what you should pay attention to. There will be twitching of those muscles or tetany, airway compromise because of the laryngeal spasm. Okay? So our correct answers here will be the following. Letter A, we got letter E, and letter F. These are specific manifestations of hypocalcemia, guys. Alrighty, let's move forward to number 11. A patient's calcium level is 12.1 milligrams per DL. What nursing action is most appropriate for the care plan? Is it A, restrict patient to bed rest, B, check lung sounds every 4 hours, C, assess for Trousseau's and Schwarzkopf's signs, and letter D, encourage the patient to drink up to 4,000 mLs of fluid daily? Your answer, please. Your patient has hypercalcemia, 12.1 milligrams per deciliter. What is your nursing action for this patient? Will you restrict their activity to bed rest, or are you going to check their lung sounds every 4 hours, or will you assess for Trousseau's sign and Schwarzkopf's sign? Guys, your patient has hypercalcemia, not hypo. So if you answered letter C, this is incorrect. These are manifestations of hypocalcemia. So letter C is out of the way. Hypocalcemia. Your patient has hypercalcemia. You're eliminating these two. Nope. Your patient has this. If you answered letter A, restrict patient to bed rest, will this help the patient? Remember that when your patient is going to be placed on bed rest alone, this will actually cause calcium movement from the bone cells into the circulation. This can lead to bone resorption. Remember, guys, if there is decreased physical activity, decreased weight bearing, this will allow the calcium ions to migrate from the bone structure into the intravascular compartment. This can lead to hypercalcemia, right? If there is poor weight bearing on those bone structures, not supposed to happen. What about letter B? Check lung sounds every 4 hours. Every 4 hours is quite routine, but is that the appropriate nursing action to follow up or to monitor the hypercalcemia? Well, it doesn't really address the hypercalcemia this time. So we are eliminating that. If you answered letter D, encourage the patient to drink up to 4,000 mL of fluid per day, that is appropriate because when there is hypercalcemia, you are supposed to prevent the formation of the kidney stones. This can lead to the renal calculi. Okay, so the action alone will prevent, or it prevents, renal stone formation. You need to keep flushing their renal system to get rid of those calcium ions from their body. That's the main reason. Prevents renal stone formation. Okay, so your patient should have increased hydration. All righty. There's other interventions aside from increasing the hydration. If the patient will, another is the administration of diuretic, which is the furosemide or Lasix. This can also promote the excretion of calcium ions. So take note of that. This will allow the excretion of the excess calcium ions rather. Number 12, we're almost through. A patient with a serum calcium level of 7.0 milligrams per DL presents with which of the following findings that the nurse should prioritize reporting? Is it A, stridor in the larynx, B, generalized tiredness, C, constipation for past 4 days, D, tingling around the lips? Your patient is hypocalcemic at 7.0 milligrams per DL. Present with which of the following findings that the nurse should prioritize reporting? Is it A, stridor in the larynx? Is it B, generalized tiredness? C, constipation for the past 4 days? Or D, tingling around the lips? Guys, please take note about your calcium level. Serum 8.6 to 10.5 milligrams per DL. Stick to that range. Your patient's value is already 7.0. This is very low. If you had answered letter D, tingling around the lips, is this a priority manifestation, tingling around the lips? We are asked about prioritizing the reporting. So we are going to select that manifestation that is quite severe, right? Tingling around the lips doesn't really pose a threat to the airway, right? It doesn't. We know that tingling is associated with hypocalcemia, but it is not as critical compared to the laryngeal stridor. This one right here. This is a sign of laryngeal spasm, right? Severe hypocalcemia. That is the correct answer. Yeah, your patient's calcium level is very low. This one is a mild sign. It doesn't pose a life-threatening threat to your patient. So we are eliminating letter D. What about letter C? Constipation for the past 4 days. Is that life-threatening? It is not a critical symptom of hypocalcemia. And there's other manifestations, or there's other conditions that might be related to the constipation as well. But in the context of this test question, we are prioritizing that manifestation that is life-threatening, which is basically stridor in the larynx. Your patient's airway is greatly compromised around that time when it happens. Generalized tiredness, as I have said earlier, the tiredness, the muscle weakness, those are conditions that can be associated with other imbalances. We know that fatigue is also a sign of hypocalcemia, but it's not really going to call for it's not as urgent compared to the stridor of the larynx. Okay, so again, guys, prioritize the airway. We have our answer, which is letter A. Prioritize the airway. Okay, let's have number 13. A patient in the ED with severe fatigue and confusion has lab results pending. Which lab value needs the most urgent attention? Is it A, arterial blood pH of 7.32, or B, serum calcium level of 18 milligrams per DL, or letter C, serum potassium level of 5.1 milliequivalents per liter, or D, arterial oxygen saturation of 91%? Patient came into the ED with severe fatigue, with confusion. The lab results are pending. But once those labs will come out, which of those would require most urgent attention, if in case? Will that be letter A, arterial, or is that a calcium level of 18 milligrams per DL, or a K level of 5.1, or is that going to be arterial oxygen of saturation of 91? Prioritize. Okay, if you had answered letter D, arterial oxygen saturation of 91, I know it is low, but does it require urgent attention? Not really. Below normal, but it doesn't require urgent attention. Less critical. Which is more critical this time, according to the options? Well, there's no other than letter B. Your patient has severe hypercalcemia. Hypercalcemia. Your patient here is at risk to developing cardiac dysrhythmias. Yeah. The heart muscle is going to be so sensitive. It will be so irritated that it will not be able to control its irritability anymore. Cardiac dysrhythmias that are life-threatening will require immediate attention. If you had answered letter C, this is mild hyperkalemia. It doesn't really require immediate attention. So you are going to eliminate this one. If you answered letter A, pH of 7.32, what do you think about 7.32? We know that this is acidosis, right? This is acidosis. But comparing the two, hypercalcemia that is so high, yeah, those life-threatening dysrhythmias need to be addressed urgently this time, okay? Not the pH of 7.32. Pick what is worst here, okay? So our correct answer here is letter B. Life-threatening dysrhythmias. And of course, if you're just going to base on the value of 7.32, I know that this is acidosis, but the information is so incomplete. 7.32 pH is, it doesn't really, for me, it is meaningless because it's just the pH. You need more information on the bicarbonate. What else? You need to have information about the partial pressure of the carbon dioxide because we need to know if there is compensation or not. So basically with that just information, it will still require more investigation. So you got to look some more of those other lab results. So 7.32 doesn't give us a better understanding about the potential acid-base imbalance. It doesn't. However, if you have that value that is already high, severe hypercalcemia, this is much more life-threatening. Okay, so that's the rationale about there. Thank you, virtuous lady. Let's have number 14. A patient has been on normal saline IV and has a nasogastric tube. What assessment finding should the nurse report immediately? Will that be A, oral temperature of 100.2 degrees Fahrenheit, or is it B, serum sodium level of 139 milliequivalents per liter, C, gradual decrease in level of consciousness, or D, weight gain of 2 pounds equivalent to 1 kilo since admission? So your patient has been on normal saline IV and has nasogastric tube. You are asked to identify what manifestation you should report to the medical provider immediately. Will that be A, B, C, or D? Try to eliminate the options first before finalizing your answer. Your patient is getting normal saline IV infusion, and they have a nasogastric tube. They have a nasogastric tube. Remember about that nasogastric tube. This can potentially cause the drainage of those important electrolytes. And you are also administering the normal saline. Which of those would place higher priority? If you had answered letter D, weight gain of 2 pounds since admission, we know that this is a significant abnormal finding, right? This is already a weight gain. That is significant. This is telling us that there's already fluid retention. But if you are going to compare it to letter C, which is gradual decrease in the level of consciousness, this is a big deal, right? This is a major issue. What do you think is happening in our patient with a decreasing LOC, a gradual decrease? This could be result from electrolyte imbalances. What type of electrolyte imbalances? Maybe it could be hypernatremia, or maybe hypocalcemia. And so if you're going to really focus into the level of consciousness of your patient, remember about the cerebral edema. Yeah, remember about that? If there is going to be major shifting of those fluids from the vascular compartment to the brain cells, this would really require immediate intervention, especially that you are noticing that your patient was formerly alert during admission, maybe, and then subsequently decreasing their level of consciousness, getting drowsy, and maybe getting more lethargic as the time goes by, or maybe now becoming obtunded. Yeah, that is a huge change in your patient's level of consciousness. You should prioritize that because this is a possible effect of an electrolyte imbalance, or could be imbalances. And letter B, 139 milliequivalents. This is within the normal range, right? We know that the sodium level is supposed to be around 135 to 145 milliequivalents per liter. So take this one away, letter B. If you had answered letter A, oral temperature of 100.2 degrees Fahrenheit, that is considered fever, right? Slight fever, but will it call for an immediate reporting? Of course not. Slightly elevated. It doesn't require immediate reporting. We have to deal with those manifestations that can be much more life-threatening, especially brain function. Yeah. Possibly our patient is maybe experiencing elevation of their ICP, decreased level of consciousness. ICP increase is one of those. All right, let's deal with number 15, which is the last item of the day. We're going to do some more exercises tomorrow. A patient on IV furosemide for hypertension presents with which of finding that requires the most urgent reporting? Is it A, blood glucose level of 176 milligrams per DL, or B, serum potassium level of 3.0 milliequivalents per liter, or C, orthostatic systolic blood pressure drop of 12 mmHg, or recent blood pressure reading of 166 mmHg? Take note, guys, that our patient is getting Lasix for hypertension. The case is on a patient that has hypertension. What do you are asked? Which of these four manifestations require most urgent reporting? Yeah. If you had answered letter A, blood glucose of 176 milligrams per deciliter, we know that this is elevated, right? It is a concern, but it is less immediate or less critical than the other manifestation. Less critical. Abnormal, but less critical. We are eliminating that one. Recent BP reading of 166/92. Is it critical? Not really. Your patient has a hypertension, so it will not really call for immediate notification. They have hypertension. We are going to deal with that. It will require follow-up, but it's not going to require immediate reporting. Nope. If you answered orthostatic systolic blood pressure drop of 12 mmHg, orthostatic blood pressure drop of 12 mmHg, we know that this is going to be a concern, right? 12 mmHg drop. But coming from a reading that is already high, will this pose a greater concern since they already have the hypertension? Remember that the scenario is on a patient that has hypertension. So, if they're being treated with the Lasix, of course, it will cause a drop, right? Yes, it can. So will this call for a critical reporting? No, it isn't. We know that it can cause orthostatic hypotension, but is it as critical compared to letter C? No. Your patient that has hypokalemia, you should address that first before you're going to administer the Lasix, because once you give that Lasix, it will cause some more hypokalemia. This can lead to further low potassium. Severe hypokalemia. Ruhaina, the potassium level is supposed to be between 3.5 to 5 milliequivalents per liter. Serum potassium level of 3 is low. Okay? Before you're going to administer the Lasix for this patient that has hypertension, make sure that you are going to replace this first. Because again, when you are giving the Lasix, Lasix is known as a potassium wasting drug. Yeah, you got to be careful about Lasix. It is a potassium wasting drug, so make sure that you tell the medical provider first, hey, I think we have an issue here. You gave me an order to administer Lasix. However, our patient has a potassium level of 3. Do you want me to address the potassium level first before administering the Lasix? That should be our direction of care. Make sure that you address it first before lowering the patient's blood pressure, as we know that this is something that can lead to more hypokalemia. And there are other means of reducing the high blood pressure other than Lasix. There are other modalities of treatment. So make sure that you notify the medical provider regarding the electrolyte imbalance. Okay? There's other means of reducing the blood pressure. There are beta blockers, there are ACE inhibitors, there are calcium channel blockers. Yeah, there are so many choices. So make sure that you notify the medical provider first, and then we'll proceed with the treatment of the hypertension. Okay, so that's it for today. I hope that you're learning from this imbalances in fluids and electrolytes. We'll be digging some more as we are going to talk into the endocrine concepts, which are closely related to fluids and electrolytes. So this will be our bridge. And again, we'll tackle some more about fluids and electrolyte imbalances tomorrow. So again, guys, thank you for your participation. And I'll see you again at 9 p.m. Eastern Standard Time tomorrow. You have a great day and you stay safe. Bye-bye. And please don't forget to enroll into our NCLEX program as well. Make sure that you check out our links below. We have updated our course for the NCLEX program. Please check our website at Stancoast, NCLEXcoaching.com. Check the description box below. Don't forget to like this video. Don't forget to subscribe our channel. And also don't forget to share this video to your friends who are preparing for the NCLEX. Bye-bye. Have a great day.